Oh, hi. Right, Liz. Well, you and I are here. That's brilliant. Thank you for being so prompt. So, hi everyone who's joining. Thanks for joining. I put the advert for this live on quite late. Apologise for that. So, I'm just uh, making sure Liz can join. I don't normally host these, so I'm not very good at hosting. I usually just join. Um, Hi.
Hi.
Oh, hi. Nice to see you, and thank
You
you.
too.
I know January's a pretty grim month, and but every month seems to be pretty grim at the moment. So it
I
doesn't
know.
matter which month we do. So thank you for coming on. I think we had talked about doing this live for a while.
Yeah.
Things just keep coming up. So and what we were going to talk about was really quite general. I think our own experiences and how we can just, I suppose, ideally be voices of reason for women who want to know
Yeah.
about it, because I think there's quite a lot of confusion about it.
Definitely. Definitely.
So, how to start really? I mean, I'm usually the guest, so I'm usually waiting to, but I think really having a guest is phenomenal because you are a I mean, you've been through all sorts in your life, but you're a breast
Yeah.
surgeon who's treated women with breast cancer and I'm sure some men over many, many years. And you got breast cancer yourself. So you and I are quite unusual because I'm an endocrinologist who got breast cancer at
Yeah.
went through menopause. And I think particularly women who go through menopause at younger ages, their treatment often
Yeah.
puts breast cancer at younger ages, but the treatment puts them into menopause, so that topic is relevant. And I think what I've seen, and I'm going to have to stop talking and ask you to talk quite a lot in a minute,
So don't worry.
but what I've seen a lot in the media is a lot of talk about menopause and breast cancer, and there's a huge difference between talking about the risks of treatment for menopause, such as hormone therapy, increasing the risk of breast cancer, which for many years was sort of overstated for many women, and a lot of women
Yeah.
go using hormone replacement therapy because they think they're going to get breast cancer, and actually those risks are relatively small. But it's
Mm.
a different ball game when you're talking about going on systemic hormone replacement therapy after breast cancer, and
Yeah.
that's I think what I'd like for us to debunk or to explain and to
Yeah.
talk about that. Any questions that people have, if I can navigate the questions, and if not, I can try and do those on the recording. And then, how you navigate menopause, how you navigate breast cancer.
Yeah.
Do it. So,
I th-
I mean, for my audience, not everybody will know you. So I've given you a brief introduction. So why
yeah.
don't you start talking? Because it'd be nice to have somebody else talking. I just talk too much. So it'd be nice for you to
Don't worry. Me too. Thanks, Annice. And it's great to meet you again. So I wrote the Complete Guide to Breast Cancer to help women and men understand what happens. And Annice wrote the Complete Guide to the Menopause. And we are both medical experts who have both had breast cancer. So we're coming at this from a very different point of view, but also a very educated point of view. I was a consultant breast surgeon who got stage 3 breast cancer when I was 40. I was fit, I was a triathlete, I was slim, I had no risk factors, but often it's just bad luck. And as a surgeon, I never really knew how to treat the menopausal symptoms my patients had. We had a GP specialist who did that. I didn't really know how bad they are because patients didn't tell me and I didn't think to ask. It'll just be a bit of a hot flush. You might get a bit of vaginal dryness. Off you go. Put up with it. I'm sorry. That was a lot. That was the training that I had. And then I had an instant menopause. And I think it is much worse, as you said, for younger women in their 20s, 30s, and 40s. And I wanted to throw my tamoxifen down the toilet because they made me feel so ill. And not everybody feels bad. Some people just sail through it. But that instant, the hot flushes, the night sweats, the loss of libido, it's really, really hard to deal with. And there is help available, which we'll talk about. But I think let's just start with HRT. HRT and breast cancer is a really, really controversial topic. Now, I'm going to talk mainly about women who have estrogen positive breast cancer, and that means your breast cancer cells feed off estrogen. And that is why we give you the hormone blockers, tamoxifen, and the AIs to stop you either producing estrogen or to stop breast cancer cells recognizing it. And the reason is we know that breast cancer either comes back in the first 2 or 3 years or 5, 10, 20 years down the line. And we're giving those drugs to try and stop it coming back really in the first 2 to 3 years. Now, a lot of breast cancers will metastasize at the time, and there'll be little cells floating around your body that are dormant. They're asleep. They can't find a friend. They can't grow. And what these hormone blockers are doing is stopping those cells waking up so they can't grow and spread. Now, we know that in some women, their cancer comes back despite these tablets. And that's because breast cancer is a really sneaky bugger. I'm going to swear because it's horrible. It can metastasize. It can develop resistance to one drug you put on another. But we do know that estrogen makes them grow. We also know that the side effects of the menopause can be horrible, and a lot of women don't take their tablets. And I've wanted to stop mine for a couple of months because of how they made me feel. And it's a real risk. And there's been a lot of controversial studies, case studies looking at, well, these women had ER-positive breast cancer and they had HRT and they were fine. But actually, we finally got evidence to show that randomized studies where women with ER-positive breast cancer were either given HRT or they weren't, those that had HRT had a worse outcome. There were more deaths and there were more recurrences. And I know there are reasons to give women with ER-positive cancer HRT, and I think often they're almost suicidal with how bad those symptoms are. But people need to know that there are side effects, and those side effects could make your breast cancer come back, so it is incurable and it can kill you. And my worry is that that risk isn't being fed through to women who are taking HRT without really a second thought.
Absolutely. Oh gosh, you put it all so well. I've got so many questions and so many things to sort of add on to reinforce what you've said there. I mean, it's all so correct. That's the problem with some of these treatments. The fact that you describe...
So we're talking about systemic HRT, not vaginal, which is completely safe. Vaginal estrogen is fine, but this is just systemic HRT.
So if I just go back to one of the earlier things you said, which I think very, very relevant, is that you were a breast surgeon and you'd give your women life-saving treatment. Literally, we are talking life-saving. I'm not talking, this is not minor things. This is huge. You're saving people's... And as you say, they won't mention menopause symptoms to you because at the time they're so grateful that you've done a treatment which, is going to allow them to see their family, for many years to come. For their children to have parents, for their parents to have children, whatever. But they don't ask you the questions about menopause, and it's often the bit that's ignored. And you mentioned that when you were doing your practice, and I think it's still very much the case now. And I do think that change, because if a woman is struggling with tamoxifen or struggling with menopausal symptoms, or whatever the situation she's in, she's gone through a major life event of a cancer diagnosis and she's got all these symptoms, and the breast team are not saying anything about what she can do to help herself, what support she can have, what treatments might... And then she might go on social media, and social media says, well, just take HRT, it's fine, it'll be fine. That woman has not actually had an informed discussion about that. And that's what I think is crucial now, because 20 to 30 years ago, women were not living long term. Young who got breast cancer were not living long term because we didn't have the treatments that enabled that. And now we do. Those women are living with a burden of symptoms, and breast cancer treatment teams need to actually bring in menopause management as an integrated part of their care, because their long-term survival rates are going to start going down because women are taking treatments from sources, perhaps not even discussing it with their cancer teams.
Exactly.
And
I think we rely a lot on the GPs knowing what to do, but most GPs are confused with prescribing normal HRT in the menopause. They have no idea what to do. So I found out as a patient through an amazing oncologist in Brighton called Richard Sincock. I was tweeting and he messaged me and said, Liz, did you know that you could have antidepressants? And I said, I'm not crazy. He said, no, they actually help the hot flushes. We are not giving them for depression or anxiety. And I went, what? How did I not know this? And I was a breast cancer surgeon. I think it's why we both wrote in our books chapters about breast cancer, to try and get this education out there, because there are so many things women can try that might help.
And there's a lot of talk about antidepressants, because if you're feeling menopausal, you're hormonal, you have a meltdown because your hormones are just all over the place, and that can sometimes make you emotional.
Yeah.
And you go into your GP surgery, and actually you're not depressed. You've just had a bit of a hormonal, just like a woman, a baby, or will have baby blues, or women who are at the time of the month can have emotional symptoms. And you go and you say, look, I've got all these symptoms, and I think I might be menopausal. And the GP just gives you a prescription for antidepressants. It's confusing, isn't it? But you think, and actually, I'm afraid there's still a stigma around mental health, which there shouldn't even be about. That's used for depression, that helps with menopausal symptoms, but actually I think it's the stigma that's still in there. But yes, certainly venlafaxine, which is an antidepressant, which I utilize in certain situations. I will always individualize my management of my patients, but venlafaxine is used to manage severe hot sweats, sleep disturbance, irritability.
As is citalopram, which I take.
And citalopram, I think citalopram is a really nice one, because there's far less, it seems that there's less side effects. I find more women take citalopram than venlafaxine. But venlafaxine had all the research data on it showing that it significantly reduced hot sweats and flushes. It's completely safe, as is citalopram, with any menopause adjuvant therapies that you might be taking. But the dose, certainly the dose of venlafaxine that's needed to manage the hot sweats, the night sweats, the sleep disturbance, the mood, all of those, is much lower than the usual antidepressants. And I think generally the dose that's needed to manage menopausal symptoms is lower. But I think women come into it thinking, but I'm not depressed. This is not depressed. Menopause.
Well, they think it's all in my head. I'm not imagining it. This is real. But actually, it does help with the hot flushes and the night sweats. It's made a huge difference to me. Another drug also is clonidine, which is a heart drug, but that can also help with the hot flushes and night sweats.
Yeah, and I mean, I use clonidine quite a lot actually in my older patients who might have had menopausal symptoms settle down and then come back really, really badly, but they might have really high blood pressure, and they're several years, they might be in their 60s, they've not been on hormone therapy, so they haven't not having breast cancer. They're just struggling with symptoms. And if you've got somebody who might have increased cardiovascular risk, so because they've got high blood pressure or diabetes or whatever, clonidine is great. I mean, the problem with clonidine is it can lower your blood pressure. So bonus if you've got high blood pressure, but if you've got low blood pressure, it can sometimes cause side effects. But it's all about, finding the fit that works best for a particular individual. Lots of people are making nice comments.
So people are taking Prozac. You can't have Prozac with tamoxifen. There's a massive drug reaction, so you can't have Prozac in there.
There's always options. So there's different. It's fine. I think citalopram's fine with tamoxifen as well. But there's the liver enzyme reactions, isn't there? And then obviously there's somebody saying that their breast care nurse isn't being helpful, and that's what I really want to see change. I think it's so clear that we really, really need that care, that advice, the advice that we're talking about now. It's not rocket science. It just needs a team to deliver that, and it needs to be done on a wide scale. And I think there are some centres that are providing more integrated menopause care for women breast cancer, and I know in Manchester we're trying to do that, but it's just, again, it's a bit like with everything else to do with women's health, it's a postcode lottery as to which teams you're under.
So someone said with triple negative breast cancer and HRT, theoretically it is safe because your cancer isn't driven by estrogen, but oncologists are still quite reluctant because there's always that, what if your cancer metastasized, because triple negative can change and develop estrogen receptors, and what if HRT stimulated that? And there is always that risk of what you're willing to take as a patient.
So there's two things. There's a small risk of estrogen receptor positive metastases secondary. Is small, but it's there. And then there's the risk of which is a slightly higher risk if you get a second primary. So if you haven't had a double mastectomy, there's actually a higher risk of getting a second primary. And of course that links in with some of the genetic forms of breast cancer. If you've got breast tissue and you've had a triple negative, you can also get a second primary. And again, a lot of necessarily, sorry, I should have turned this on silent. I'm just going to do that now because I turned it on to silent. And I've completely forgotten what I was saying now, but the difference between a second primary and a secondary, they sound similar, don't they?
And they do, but they're not.
Everyone knows what we're talking about, but we're not. So you can have a single breast cancer and be cured, and then you can have another primary breast cancer and you can still be cured.
In the same breast or the opposite breast. Exactly.
So if you've had a double mastectomy, which some of the women with genetic forms of breast cancer will have had, then they're going to get a second primary. But most women don't have a double mastectomy. But a secondary cancer means you cannot be cured. So if somebody says to me, well, I've had breast cancer, but I want to take HRT because it's going to protect me from heart disease or osteoporosis in 40 years time or whatever, I would say, well, it's not going to protect you because you're doubling your risk. I mean, the data suggests doubled risk of recurrence, which would be secondary, would kill you because secondary. And I don't like to talk about it, and I feel comfortable talking about it because I've been there. I am a breast cancer survivor, as you are, and I think a lot of doctors don't want to. It's like they don't want to.
No, we don't.
Let's not talk about.
No, and as a breast cancer surgeon, it was really hard knowing when do you tell patients what the symptoms of recurrence are, because you're giving them the news after surgery, or it's the 1 year that thing looked great, or the 5 years off you go. It's really, really hard to bring that up and say, despite everything I put you through, it might not work. This is what to look out for. It's really, really hard to do that. But I think we need to be that honest. And actually, the biggest reason that breast cancer come back is often people being overweight and not exercising and binge drinking. And if you lose the weight and do weight-bearing exercise, that will reduce your risk of osteoporosis and it will reduce your risk of heart disease, and it's free. And there are no side effects.
No, there's no side effects, there's no downside. And it actually, a lot of those lifestyle approaches that reduce the risk of recurrence also help with your menopause symptoms.
Yeah.
So,
someone's asked about probiotics. There are no supplements that have really been recommended for patients who've got breast cancer to help with the menopause. Nothing's been really shown to work, but I don't know anything about the nutritional stuff. Sorry to interrupt you, but alcohol is the big one, isn't it, that we should really avoid?
Well, going to probiotics, I think I never talk about it. I always say, go and look at Tim Spector's work, because Tim Spector, epidemiologist who specializes in what we call the gut microbiome. So if anybody wants to know about the gut and what you do about the gut, listen to him, because he is a top expert in that. He does all of the proper peer-reviewed studies in all journals. He publishes in Nature and Cell and all of that. Wow, amazing, those journals. So he's the one to go to. There's a lot of sort of pseudoscience around probiotics. Go and get Yakult or one of these friendly yogurts. It's not thought that on their own there's any data that helps at all. But having a healthy diet and having a healthy gut helps with your overall well-being. And I know Tim Spector talks about mood and the link between gut and mood, which is, I don't understand that side, but it certainly seems to be, well evidenced. So, So in terms of managing menopause after breast cancer, I mean, you probably feel the same, is that having knowledge is hugely helpful, but having not looking at a research study that is, one single study in isolation and not looking at the whole, because there's lots of studies that might suggest something's good, but then if you look at a range of studies, the balance is that it isn't beneficial.
And I think the problem is most of the general public don't know how to interpret scientific studies, and they're hard for me to interpret as a doctor. And you see one person promoting a book that one man wrote and they assume that's the law, when actually it's not based on science. And it's really hard for you watching to understand, who do you believe, who do you not? And that's where it's trying to listen to as many educated people as possible, but make sure you know the risks. For me, the menopause, I could break into three main problems. One was the hot sweats and the night flushes and not sleeping and the tiredness, which the drugs kind of helped. The second was kind of the weight gain. Now, I'm slim and I put on 5-6 kilos, which is about 10% of my body weight, which is still pretty big. And I used to say tamoxifen, they don't cause weight gain. but I think it's the menopause that does cause weight gain naturally. And you can lose that weight, but it is bloody hard work, and it involves cardio and weightlifting and eating more protein and less carbs at night. And there's a brilliant book by Stacey Sims called Raw, which talks about female athletes throughout their life. And she's got a great chapter on athletes at the menopause and how they can maintain their fitness. It is hard work, but it can be done. But the biggest thing for me that a lot of people have been talking about was sex life, libido, painful vagina, painful sex, painful peeing, that we don't talk about because of women. We don't talk to our partners, let alone our GPs. And you must have had patients who've had those issues or experienced it yourself.
Absolutely. And to be honest, as many patients who are not breast cancer survivors as who are. So even women who are on systemic hormone therapy will often not get the sort of the tissue absorption down there. And there's other complex factors down there. And I guess there's probably genetic factors, because some women get away relatively lightly, and some women get really severe symptoms even when they're in perimenopause, when they've still got some estrogen hanging around, or when they're on HRT. So it's a real muddy issue. I know you've done a lot of recent stuff about sort of sex and intimacy in relation to menopause and after breast cancer. And the thing that I see are themes that I don't these themes are in that I see in women who are breast cancer survivors, and I think they think it's only me getting this, and the only reason I'm getting it, these symptoms, the weight gain, the tiredness, the aches and pains, or the difficult down below problems, and the sex drive issues, it's because I can't take HRT, it's because I've had breast cancer. And the thing for me is that I see everybody in my clinics. I mean, my clinic rammed with all sorts, and it's wonderful, and I'm very, very lucky that I see a huge diverse set of issues in relation to women's health across the lifespan. And it's not just women who've had breast cancer that get these problems, and it's not just women who can take HRT. It's not women who I see and they have problems and then they go on HRT and it's all cured. It's women who are on HRT. So it's a complicated set of symptoms, and other aspects of your life, like stress, for example, as in stress, mood issues, particularly what I call chronic stress. I mean, I talk in my book about allostatic load, which is a well-recognized neuroscience term for the impact of chronic stress, and it trumps your healthy hormones. It stifles your well-being, and it can affect your immune system, and it can affect
I think
infections.
Anecdotally, I would see a lot of women who we juggle balls in the air. And I'd see women who had a lot of stress in their life, divorce, move, change jobs, something had happened, someone had died, and then they get ill. And I've been as guilty of just doing everything until I either mentally or physically break down. And I think it's realizing we need to give ourselves a break and be a bit selfish and just take time for us.
Yeah, I think that is, and I do see that as a difference between women and men, because men will always say, somebody else is going to do that job, so I won't worry about it. Women will always go, I need to get that job done quickly.
Or I can do it better, or he won't do it right. Or no, I need to do this, so don't trust the husband. It's all that kind of.
Women today, and this is, I mean, it's a generalization, and I don't like to generalize, but in general, it's, I don't know, you talk about women are from Venus, men are from Mars, is that, that old story. But women today are guilty of having unrelenting standards. Women today, particularly as they, go through adult life, and because they're a victim of their own success, because we are working, we're having kids, we've got social lives, we're doing everything. But to do that, we have to kind of juggle lots, and we have unrelenting standards, and you can manage it. Many women can manage it for a period of time. But if you suddenly then have a breast cancer diagnosis, or, go into menopause at a very busy stage of your life, you've got a challenging job, it can be a bit like the straw that breaks the camel's back.
Yeah, exactly.
In lockdown, in the pandemic, everybody's struggling. The number of people I've seen in recent weeks who are not in menopause but are just really struggling. Teenagers are struggling. I think what we can also do is we're doing all of these things. We've got so much on our plates, and then we feel really rubbish in January, and we think, oh, it must be menopause because we are over 40, or we've had breast cancer and we're on medication, it must be the tamoxifen. But actually, I think that one of the gifts that I have is I see so many people and common themes that I think it's not really just that issue. It's never a single, always muddy, it's always complex. And you're so right, there is not enough self-care among women. And I think self-care gets a bit of bad press sometimes on social media, because people say, well, you know, if everybody's going on about self-care, they're just being selfish or whatever. But nothing could be further from the truth. If you're with unrelenting standards, your biggest challenge, and I would say this is you know, this would be a New Year's resolution to actually keep. I'm not keen on New Year's resolutions if anyone follows me, because I'm just going, don't, they're just broken, just do.
Yeah.
But if you're going to make one, apply some self-care. Apply some self-care and keep it in something every single day.
I used to tell my patients to go and sit in the bath with a glass of wine and a book for half an hour and just say, this is my time. You can do that once a week, half an hour, and think, no, just that little bit that's just you.
Yeah, well, I tell you, but just before Christmas, I was so busy running up to Christmas, and what I did, it wasn't quite the bath and the glass of wine, but I love going to my gym, and I can never do 2 classes after each other. They're all 45 minutes now, and I can't do two gym. I'm lazy. I admit that I'm a bit lazy when it comes, or I get bored doing my own training in the gym. So I go to classes, and I think it was a Thursday or a Friday that just before, because you know that week, and I was off work that day when I normally had a clinic, and everything was kind of calm at home for a change. And so I thought, I'm going to go in the morning and I'm going to do 2 classes, because they're 2 classes that I really like.
Yeah.
And I went and I did 2 classes. Oh my God. And I always feel so amazing after exercise. I know women who have got aches and pains struggle with the concept of it, but if you build up small amounts, it's just, the endorphins are just, there's nothing like it. And then I went down and I treated myself to this green smoothie. I put it on one of my Instagram stories, and I just sat there with my smoothie after my exercise. And I just thought, oh my gosh, I couldn't feel any better. I don't think I could feel better, you know. And I've never had HRT. I mean, I'm 10 years out from breast cancer.
Yeah.
I know, because I know what I need to be doing, and I know I do it. And I see sometimes, you know, I've learned for many years from my patients. I say, this is where you're kind of going wrong. Tweak this, tweak that. And, you know, I've utilized lots of what I've learned from my patients. And so I'm definitely not that person who says, you know, well, it's not fair for me because I can't take X treatment or Y treatment.
Yeah.
You know, I'm never going to be well. Well, to be honest, I feel better than a lot of my patients do. So
it's great. I'm
not saying that to show off. I'm saying that because it's not rocket science. It's actually
being empowered and being in control, isn't it?
Yeah. And the exercise, a lot of people hate the word because they say, look, you know, I haven't done exercise for 20 years. I haven't, and I know you're different because you did loads of exercise, and it's actually managing to keep going through that, isn't it? If you've already a lot. But making small changes is just, I mean, I talk about microdosing on lifestyle, because if you do tiny amounts, you don't notice it, and then you can just build on it gradually and dovetail it in. And a habit, if you build it in as a habit, habits are difficult to break. Resolutions are really easy to break, right? You do a resolution, it's unsustainable, you break it. You build a habit, and then it just stays.
Exactly. And another good reason to exercise, we know that if you exercise, you do weights and aerobics 2 or 3 times a week, it will halve your risk of breast cancer recurrence.
Yeah, it's unbelievable.
It should be the first drug. Now, someone asked to hear a bit more about our own personal stories with hormone therapy and cancer, so I can tell you about mine if you like. I had a big cancer. It was lobular and ductal. It was about 6 centimeters. So I had chemo first, which put me into an instant menopause. And then I had tamoxifen after my surgery to stop it coming back. And it actually ended up being about 13 centimeters in size, and it had spread to 3 of my nodes. And I found tamoxifen really, really hard. But on top of that, they gave me Zoladex. Because I was young and it was big, we sometimes give Zoladex to switch the ovaries off to reduce the amount of estrogen tamoxifen has to block. And it was only another 1 or 2% reduction in my risk of recurrence, which was about 60%. And after 6 months, I'd had enough. Partly I'm skinny and I didn't have any tummy fat, and I found the needle really uncomfortable. And it just, every 4 weeks, I would just have another menopause hit. And I asked my oncologist, and he said, fine, we'll stop. You're not actually getting that much benefit from it. But 2 years after my first diagnosis, I had a local recurrence on my chest wall, which meant I had to have my ovaries out and be switched onto letrozole because I had a recurrence on it. The hardest bit for me in all of this was the sex life, because I was newly married, I had no libido, and after my ovaries were out, I didn't have any estrogen at all. And it was really hard to make my husband understand that I still fancied him. I just didn't get wet. Sex was painful. It could feel sometimes like marital rape because it was so sore, you don't know what to do. And it was through people on Twitter that I discovered help. But many GPs and many oncologists and gynecologists don't know this and don't like prescribing it. So this is the battle. You can read our books and you can take it to your GP and say, look, for goodness sake, it is completely safe to have vaginal estrogen if you're on tamoxifen or anastrozole or letrozole or exemestane. It does not increase the risk of recurrence. And the amount of difference it makes to lubrication down there, to stopping cystitis, as well as painful sex. You should be allowed to get, yes, lubricant free on prescription, but some GPs are struggling with money and they're not always doing it. But lubricant should be your best friend. Use it all the time to make things help. And there are things you can do, but that's the bit I really, really struggled with.
And lubricants are useful for all women. I mean, I've got lots of patients who are on systemic estrogen HRT. They're on vaginal, and they still have problems. And the lubricants and the moisturizer, the longer acting moisturizers, I find, particularly for women who are not using vaginal estrogen, the vaginal moisturizers like Replens, for example, is longer acting. So it's a little bit like with, you know, obviously if you've got vaginal atrophy, you've got thinner tissue. So if you're moisturized on it, it's a little bit like eczema on the skin. If you keep it moisturized, it won't get so inflamed. And then I find with the lubricants, there's and then there's others, there's silk, and there's
Sutil, which is another silicone one.
Well, they're slightly different. Some of them are thicker, some are thinner. They've got slightly different textures. So if I see sometimes women who go, oh, I tried that lubricant and I didn't like it, and they think then all lubricants are the same, and they're actually not. Definitely worth trying different lubricants. You've just given your story, and you talked about the local recurrence, and again, people get confused about those, because if you have a local recurrence, that is not the same as a secondary metastases, just for the audience. But what a story. I mean, pretty dramatic. My story is not the same at all, and I feel like, you know, so my story is that I was 41 and I found a lump. I don't know how you found yours, but I just found a lump one day and wasn't quite sure what was going on. So I showed my husband. He said, we need to go to the breast clinic. Went to the breast clinic. She said, it was the female breast surgeon, actually, who's wonderful and a good friend of mine for over many years, a work colleague at the hospital I worked in, said, oh, Annice, I'm 99% sure this is nothing. Let's just do the FNA. And so we went off and had that. And, you know, and I just thought, I went from work, and then I went back to work. And then the next day, my husband came to get me from my office and said, I won't say her name, but she wants to see us together in her office. And she'd obviously got the result back. And so I went for... this is quite an interesting story, although it's not as dramatic as yours. But I went in for the ultrasound, obviously, in the ultrasound of my axilla, and again, the that was doing the scan I knew very well. She was a work colleague, and she was assessing it and everything. And my husband went with me because I'd done the mammogram, done the biopsy or whatever, the true cut. And then she was doing the scan, and my husband went with me. He hadn't been with me to any of the other appointments apart from when she told us the diagnosis. And so the radiologist who was doing the scan said, Simon, would you like to see the cancer?
That's not how you found out.
No. I knew that there was a malignancy there. In fact, I was still hoping it would be DCIS or something, which was non-invasive. Is it DCIS? She said, no, it's invasive. I went, oh, right, okay. It was, it's all a shock, isn't it? It's a shock even to us. I mean, what it must be like if you really don't understand the lingo. Goodness knows. But this was a weird situation because my husband was sat there and she said, do you want to see on the scan? He went, no. And then he went, actually, I would like to see. So she started showing him. And then her face just went blank. She looked ashen, and we both looked at her, and we looked at each other, and we just thought, what has she found? You know, she's not a detailed ultrasound. She's showing him, and she just spent ages just staring at, the screen, and I was just like, obviously knew something was wrong, and and we said, obviously there's something that you're not liking that you're seeing. Do you want to just share it with us? And she said, I found another one. And so there was two. So basically, it was, the first one was missed on the mammogram.
Yeah.
And if she hadn't offered my husband to look in detail at what she'd seen, and he said yes, which he initially said no, and then he said yes. If he hadn't said yes, then I would have had a medical excision, and then I would have had what they thought was a local recurrence 2 years later, right? Because it was missed. So she said there's another one. So then I went for MR. My surgery was cancelled because I think that was the ultrasound that they were also looking at to see if there was any lymph nodes. I think now it's 10 years ago. So she said, right, and then the surgeon cancelled the surgery, and they did an MRI scan. They said, no, there's only two. It's all right. So
only
me, but that freaked me out totally. So I then I went through obviously the stats of the surgery and everything, and it was all good. It was two cancers, both around I think 1.2 and 0.8 centimeters, good recurrence, good resection margins, things like that, and node negative. So I didn't have positive lymph node, and I was 41. Obviously, I was premenopausal at that stage. I had no problems with my periods. And so I went to see the oncologist after having the mastectomy, and they did do a axillary node clearance.
Sentinel node,
Well, no, that she said you couldn't do a sentinel node because there was two cancers. So if you've got two,
they did it,
you have to have a mastectomy anyway. And I'm tiny, so I had the mastectomy and axillary node clearance, and then I went to the oncologist, and he just said, "Oh, it's fine, you're all done now. Then let's just just carry on, just take some tamoxifen." And for me, as an endocrinologist, I just thought, no, because any cancer, just as you talked about at the beginning, there's cancer cells, sleepy cancer cells asleep. We know that happens with breast cancer, not like any other cancer, because that's why it can come back at 5, 10, 15, 20 or 20 plus years later. And that's recurrence. That's a secondary of the, it's not a new primary, that's secondaries. And we know that. So for me, I just thought, no, get rid of the estrogen. I'll deal with it. I will deal. I'm an endocrinologist. I've managed this. I've managed menopause in my patients. If anyone can deal with menopause after breast cancer at 41, I can. So he was like, well, you don't need it. And you know what oncologists are like. I mean, they're lovely people, but they're kind of quite laid back about the whole thing because they deal with it every day. So I spoke to my breast surgeon, and she said, well, we can do the Zoladex. So that's what I had. I had the Zoladex for about 2.5 years to 3 years, and then I was totally postmenopausal. So that was all fine. The only problem I had was a bit of bleeding on the fen at some point later. But so that was because I had managed women who had gone through breast cancer treatment and become menopausal as a specialist at Christie Hospital, which is a very big centre for breast oncology nationally. I'd worked and helped women with this over many years, and I thought, well, isn't this a great opportunity for me to actually see what my patients have gone through? And and I did, and I thought, this is my opportunity to use lifestyle, to use all the techniques that I've told me, and I did. And I started slowly. I remember when I'd had my lymph node and my surgery, I had the axillary node clearance, mastectomy, and I couldn't move my arm for weeks. I did my physio, and I went out for a little walk every day, tiny. And I just built it up really, really, really slowly. And I just can't get enough. I love walking. I love any exercise I can. But it was really slow. And then, I like wine. I like food. I noticed a little bit of a change in body shape, but I was really also, because I've had specialism in metabolism, diabetes, I've also always known about nutrition. So I made sure I know prevention is better than cure. Once you've gained the weight, it's much harder to lose it than if you don't gain the weight at all. So I was very cautious.
There's two interesting questions. So one, why do different brands of the drugs make different side effects? I don't know. I didn't believe it. Especially with tamoxifen, I think it's just to do with the chemicals that they use to make each specific brand of the drug, but it can make a huge difference. And if you are really, really struggling, it's worth asking your GP or your pharmacist to prescribe a different brand.
And it's the same with HRT. We find that the same, supposedly the same ingredients, but it's obviously fillers and excipients.
Yeah, it does work. Someone said, when did you stop realizing your cancer can come back? For me, it was just time. I used to wake up every morning thinking, is this the day that comes back? And every year I'd have a scare, I'd have a cough or a headache and think, oh my God, is this it? And for me, it was the worry of wondering how long to wait to tell someone that was just destroying my head. The minute I told someone, that relief went, but then I got scared because they took me seriously. When they send you for a scan, you think, oh shit, it might be something. And I almost end up having a CT scan every year because I worked myself into such a state that this could be something. And I'm now 6 years on from my first, 3 years on from my second, and now I've got to the stage where I've kind of accepted, because I used to worry about my odds on predict. I had a 40% chance of being alive in 10 years, and oh my God, but actually it's out of my control. It comes back or it doesn't. And I've come to terms with that, and I now just live my life, and if it comes back, well, that's what was meant to happen. But that was me 6 years on. 3 years ago, I wouldn't have been in the same place. I'd have said, I still worry. And every time someone dies on social media or a friend knows, I get guilty that I haven't got cancer coming back. And I'll often just step back and switch off because I'm not in a right mental place to deal with it. And that's okay. What about you, Annice?
Yeah, I think in the early days, I was very anxious because when I first got diagnosed, as I said, it just kept being more and more bad news. She said she was 99% sure I didn't have cancer. And then suddenly there was 2. And it felt like I was on this roller coaster that was just going in the wrong direction, and I couldn't deal with it at all. And I had lots of questions, and I bumped in to my radiologist colleague who'd found the second cancer by accident. But on ultrasound, and I asked her I can't even remember what the question was, but I just remember she looked at me and she said, Annice, just enjoy the time you have. And at the time I thought, is she patronizing me? What does that mean I've got 10 minutes left? You know,
yes. Like, oh my God, what does she know that I don't?
Those words stuck with me, and I kept thinking, what does that actually mean? Because, you know, she wasn't a flippant person, and it wasn't a flippant comment. And she said, enjoy it. And I thought about it. And then I thought, what I tell how many patients I'd seen who'd had various different health issues, not just breast cancer, but many things. And you can either sit and dwell on it and think about it every day for 5 years or 10 years. And then the cancer comes back, or, you know, something comes back, an illness. And then you think, well, I knew it was going to come back, but you've ruined that 10 years or 5 years. And I thought, actually, I just need to go and live my life. I've got 2 young kids. I had a lovely friendship group who were great for me. They just go, come on, let's drink a bottle of champagne. Who cares? We've got everything to celebrate. And I'm going, have we? Really? Am I supposed to celebrate?
You do.
Mastectomy.
I drank more bubbly after my diagnosis, celebrating it's the end of chemo. Drink. Radiotherapy. Drink.
Yeah. So, I mean, I think, and it's also the same for everything in life, you know, pandemic, there's corollaries with all sorts of things. You have to enjoy the time you have, and it can be hard, and you can get stuck in the minutiae of, you know, things going wrong and things happening. But actually, we get this opportunity. And in some ways, I thought, actually, now I have to enjoy the time I have, because I don't know how long I've got. And if you're fit and healthy, you can just really be on a rat race and not look after yourself. And I've looked after myself better since I had breast cancer than I ever did before. I have a better quality of life now. I'm less tired. I'm more active than I was 15 years ago. And I'm more productive. I am absolutely I mean, I'm in this house. I've got my kids home for Christmas and things. And my mum's been staying with me, complicated story, and everything's going on. And I'm the person with the most energy in the house. I'm up first. My husband's quite a high energy person anyway, but, you know, I'm more energized. So it's not because I'm taking something that's a magical treatment. It's because I know what to do, and I just do it. And it is a boring story, isn't it? Oh, well, lifestyle's really good. But it is, you know, lifestyle has it has no finish line. It has no side effects. It has no risk. It has only benefits. And, you know, when you talk about, if you can get your weight down, that significantly reduces your risk of breast cancer recurrence. Doing, I think it's 150 minutes of exercise.
It's 3 aerobic sessions of 30 minutes and 2 weight sessions of 20 minutes. I think I'm the same. I've got a better quality of life now. I appreciate my life more. It's almost a wake-up call. So 2 questions I picked up on. One said, how do you know if it's going to come back? Your surgeon uses a computer program called Predict, which you can find on the NHS website. You can use it yourself. It's a bit scary, and that tells you, based on trials of hundreds of thousands of women, what your odds of being alive in 5 or 10 years are based on the treatment you've had. But it may be a 95% chance of you being alive, but we don't know which group you're in, which is why I kind of realized it's 50-50. It comes back or it doesn't. I can stay healthy, I can exercise, I can eat, I can do everything I can to reduce that, but I don't know which group I'm in.
Yeah, and sort of going sideways from that a bit, the thing about the lifestyle approaches that reduce the recurrence risk, so limiting alcohol, not smoking, trying to shed a little bit of excess weight if you can. It's not easy, and actually if you've got a lot of excess weight, then it's a really good idea to see if you can get specialist support, because there are some amazing specialist weight management services that can be really helpful. And building up exercise or movement, even if you can't exercise in inverted commas, but just moving, moving every hour. All of those approaches, they don't just reduce your risk of breast cancer recurrence. They reduce your risk of many other cancer primaries. They reduce
and heart disease. And most women with breast cancer will die of heart disease because it's what most women die from.
Because it's what most women die from, and the risk factors, well, age is a risk factor for cardiovascular disease in all women, and carrying excess weight, smoking, all of the and not doing enough exercise are big risk factors. But if you do those lifestyle, if you apply those lifestyle measures, you're reducing your risk of all of those diseases. And with weight-bearing exercise and moderating alcohol and not smoking, you're also reducing your risk of osteoporosis. So
exactly.
A win-win all the way.
And we know it's hard. It can be really, really hard to start and find something you like, but honestly, it should be the first drug that we prescribe to anybody with cancer. Yeah. We give chemotherapy if there's a 5% chance of it working, which means trials have shown it's worth giving chemo to 100 women. 5 of them will not die of breast cancer, but 95 will just die at the same time. We don't know who it's going to help. Whereas exercise could have a 50% chance of working.
Yeah, and obviously
crazy.
Has a lot of side effects as well. Somebody says, does brisk walking class as aerobic exercise? I would say definitely yes to that.
Yes. So someone said, if you're walking briskly enough if you can't sing.
Yes. Yeah, I've heard that one before as well.
Walking fast enough that you... Have I left the hair straighteners on? Oh my God, I need the loo. Really, really walking at quite a rate. But even just 10 minutes a day can dramatically reduce your risk.
It's amazing, and it's not talked about.
No, yoga doesn't count as strength exercise. Yoga's fantastic, but to get the really resistance, and you can do things at home. You can do lunges, you can do squats when you go to the toilet, you can do push-ups against the kitchen counter. It's using your body weight.
But yoga stress relief. So
yoga's fantastic, but it doesn't count as weight-bearing exercise.
Somebody's asking about thoughts on HRT without breast cancer. So that was what we were talking about at the beginning. The risk with HRT for all women who haven't had breast cancer, the risks are small, particularly for those first 2 to 5 years when the symptoms are at their worst, when you're going through menopause transition. So it's ideally, you should be able to have an informed discussion with your doctor about any potential risks. The risks are very low in perimenopause and in menopause, even for women who've perhaps got a family history, although that needs to be, if they're in a family history clinic, they need to have the advice.
So, and would you say that women on HRT before the natural age of menopause doesn't count because they'd be having estrogen anyway?
Correct, it doesn't count. So we tend to, all the breast cancer risks that we talk about are risks identified after natural menopause age. So younger women take HRT very safely, and the disadvantages of not taking it are quite high.
So much higher, aren't they?
Because younger women, estrogen is protective to blood vessels and bones. So if you're going into a much earlier menopause, then the benefits way outweigh the risks.
Someone's asked about soy and phytoestrogens. They are completely safe to eat if you've had breast cancer. They don't increase your risk of breast cancer recurrence. Completely safe.
Different for certain supplements. I think if you get something that's got some concentrated amount of something in it, who knows what's in it. That's the problem with some of the supplements.
But
yeah,
for vegans who are eating a lot of soy-based products, it won't increase your risk.
Yeah. So I think that's covered all, hopefully, all the lifestyle issues. Mood swings on Zoladex. And again, I think with the mood swings, you know, you're not depressed, it's hormonal related, but actually the antidepressants can actually be really helpful in regulating the mood. And I do have a problem with the fact that antidepressants get such a bad name when it comes to menopause. And I think it is, as you say, because when women are offered a prescription for antidepressant, they think their doctor's implying that it's all in their mind, but we know that that's not the case. It's just that it helps with, you know, sweats, sleep, mood, and therefore
actually there is a mental effect of the menopause as well. The mood swings are completely natural, and it may be worth, if you're on Zoladex, keeping a mood diary. When does the mood swing happen? Is it the first 3 or 4 days after the injection when it kicks in? So just be prepared to be a miserable, moody, mardy cow for those 2 days, and then you know it'll pass. But it does affect your brain, doesn't it?
Yeah. HIIT training, what are your thoughts on this? HIIT training for a few minutes a day. I'll just say I worry about HIIT training in women in menopause because you can get injuries. I know if I do HIIT, my wrists get sore.
And that's because estrogen is a natural lubricant. So in your joints, you may find normally anastrozole and letrozole will bring on really bad joint pain in the fingers and the toes. But because estrogen is a natural lubricant, you can find you get elbow, wrist, knee pain that takes much longer to heal compared to a normal injury. So don't go into it if you've never done it before, but if you're used to it, it's a great form of exercise. Plus, it doesn't take long. So you can get a good cardio workout in a much shorter length of time. But you've got to do it properly.
And there was a question about the pill, and that sort of kind of resonates with me because I took Dianet, which is a very, very high dose combined pill with 35 micrograms of ethinyl estradiol. So it's the highest one on the market.
Yeah.
There is a warning on it that it can increase breast cancer because it contains such a high amount of estrogen, but at that time there wasn't. When I took it, there wasn't a warning, and I had acne, and so it was a great one to take because Dianet helps with acne when I was a young adult, sort of in my 20s, and I took it for a few years, and then a doctor said, you can't take this anymore, it's too high a dose, and I'm tiny, so I guess the exposed dose to my breasts of estrogen with that Dianet was very high. So I can't say to the company that sells Dianet, you gave me breast cancer. That's the problem because it's too many years later. But do I think that there is a link between high dose pills, potentially in the wrong individual, potentially maybe?
Probably, but I'd rather someone didn't have to have an abortion or, you know.
Balance, isn't it? It absolutely is. But most of the pills nowadays are not, I mean, you don't get them. There used to be a lot that were. Now they're 30 or 20 micrograms of estrogen, synthetic estrogen. So yeah. Oh, Danny says she was on Dianet. Yeah, I don't know. I mean, the whole, I always thought that.
I think I took it actually for acne when I was a teenager. It was just a done thing, wasn't it? That's what you gave people.
It was the best one out for acne. So really generally well tolerated one. But I think the problem is that if you get something years after, it's a bit like with HRT. If you get breast cancer 10 years after HRT, you can't really go back to the company and say, you have to kind of, I think, identify it within 3 years. So there probably may well be a link, but I agree with you. I mean, my daughter, she's got acne and she's just gone on it, but she didn't want to go on. But you know, she's going on it for a reason, and I'll just say to her, you know, don't start taking it and never stop it. Have breaks.
Yeah.
You know, take a view. Need it going forward. I think we've got to be sensible, but you don't want to. There's loads of people saying they were on Dianet.
I know.
We've opened a can of worms here.
We have.
Yeah. Oh well. So gosh, that hour has gone quickly. We're not quite at an hour yet, but we're sort of close to it. So that's been really, really interesting, and I think hopefully a lot of people have found it really useful. So I guess maybe closing remarks. Is there anything?
I think I would say your breast care, your breast surgeon, your breast care nurse, and your GP may not know how to treat the menopause when they can't give you HRT. We don't get that education. It's luck who we work with and what we read. But what you can do is either take either of our books with you, the stuff that you'll hopefully find on breast cancer now, and say, we now know it's safe, please can I have this? You may need to educate your doctors. I've got links in my stories on the menopause about links to papers saying vaginal estrogen is safe, so you can take that information to them and hopefully they might listen. But we know how hard it can be.
And I think because there's so much talk about menopause now at this present time, I think doctors are listening a lot more, more receptive. And I think we are in a healthcare culture where often patients, whatever their underlying problem is, are more informed than often their GP and sometimes even their specialist team when it comes to this, certainly. So I would totally agree.
Be polite, but be persuasive, and just say, I read this, is it true? Could you help? And let's see if we can change the world.
I think we can. I think we definitely
can.
I think women can do more for themselves than they often realise. So I hope we've kind of emphasised that as well, and shown that, you know, you can be several years out and it can be good. It can be better than it was before. And that's what I want to get across, because I just think, you know, there's so much opportunity for women in midlife and beyond. And I think what I want is negative narratives to be, you know, got rid of, and positive narratives be the focus, because they're there. Oh well, Liz, thank you so much. I'm glad we finally got to do this.
Me too.
And I will try.
And this has been recorded, hasn't it? So it'll go up on your.
I think it's automatically recorded.
I think it is.
Yeah. So hopefully I'll just be able to save it and put it onto my IGTV. But now I'm a bit scared. I don't know how to do that. So do I just close it and then will it save?
I think if you close it, it'll come up automatically and it'll tell you it's saved, and then you can post it on the grid. It should happen automatically. So thank you to everyone for tuning in. We hope you've been able to help.
Busy time, so, and Tuesday's not a great day, so we've had loads of people joining. So thank you everybody for joining, and thanks to Liz for all of your amazing insights.
Thanks, Annice.
All right. Thank you. Bye-bye.
Bye.